Good morning, everyone, and welcome to this April meeting of the Physician-Focused Payment Model Technical Advisory Committee, or PTAC. We're delighted to have you all here. As you know, this is our first series of meetings that will include deliberations and voting on Medicare physician-focused payment models submitted by members of the public. We would like to thank all of you for your interest in today's meeting. In particular, thank you to the stakeholders that have submitted models, especially those that are here today. Your hard work and dedication to payment reform is truly appreciated. We've spent the past year establishing our processes and procedures for receiving and reviewing physician-focused payment models. We want to stress that our process is shaped by input from stakeholders. Although we begin deliberating and voting on proposals today, we are committed to listening to your feedback and evaluating our processes accordingly. We value your comments at every level, especially as they relate to our receipt and review of proposals. We also wanted to remind all of you that PTAC is a committee of 11 members, not a committee of 1. To the extent that questions may arise in the process as we consider your proposal, please reach out to staff through the PTAC.gov mailbox. The staff will work with me as chair and with Elizabeth Mitchell, the vice chair, to answer your questions. In the interest of consistency in responding to submitters and members of the public, please reach out to us through this process that we have in place. Today, we will be deliberating on 2 models. Discussions of each proposal will begin with presentations from our preliminary review teams, or PRTs. The PRT reports are from 3 PTAC members to the full PTAC and do not represent the consensus or positions of the PTAC. PRT reports are not binding. PTAC may reach different conclusions and a different recommendation from the one that was contained in the PTAC report. And finally, the PRT report is not a report to the Secretary of Health and Human Services. PTAC will write a new report that reflects the deliberations and decisions of the full PTAC, which will then be sent to the Secretary. Following the PRT's presentation, some initial questions from PTAC members. The committee looks forward to hearing comments from the proposal submitter and the public. The committee will then deliberate and vote on a recommendation to the Secretary of Health and Human Services. It is our job to provide the best possible recommendations to the Secretary, and we are excited to begin this process. I'll turn to Elizabeth for any additional comments, and then any from our committee.
Thank you, Dr. Bailey. And I wanted to just thank everybody. As you've heard, we are very committed to an open and transparent and fair process. We are eager to hear from you, and our committee has been very, very committed to making sure that we are inclusive and really looking to make this as successful as possible, understanding that these are ideas from the field, and we are hoping to expand the portfolio of models that are available.
Do we have any other opening remarks from our committee members? Tim.
Jeff, I just wanted to add that it occurred to me during yesterday's discussion that not everyone in the audience knows that we abide by the FACA rules and do not deliberate on any of the proposals except in this public setting, and so have not discussed any of these proposals except within the PRT has. And I just wanted to clarify that because I think that might not have been clear yesterday, that we are truly talking about this as a group for the first time here now in front of the public.
Thank you. Seeing no other comments from the committee members, I think it would be nice to start with introductions and also disclosures of conflicts, and I'll start with myself, or just disclosures that we are required to make to address any conflicts or impartiality issues. My name is Dr. Jeff Bailey. I'm an otolaryngologist. I am the Executive Vice President of Blue Shield of California. I am privilege to be here and leading this esteemed, impressive group. Elizabeth?
Thank you. Elizabeth Mitchell. I'm the President and CEO of the Network for Regional Healthcare Improvement, and I have no disclosures on this proposal.
Tim Ferris, internist and primary care physician at Mass General Hospital, Senior Vice President of Partners Healthcare in Boston, and no disclosures.
Hi, Kavita Patel. I'm an internist here in DC, and I have no disclosures.
I'm Bob Berenson. I am a fellow at the Urban Institute, and no disclosures.
Paul Casal, cardiologist at New York Presbyterian, Weill Cornell, Columbia, and I have no disclosures.
Harold Miller, Center for Healthcare Quality and Payment Reform. I have helped over the past year the American College of Asthma, Allergy, and Immunology on a payment model for asthma, but I have no financial interest in that model, and I do not see any conflict between that work and the proposal that's here before us today. I think also it's probably important for people to know that there is no limit on the number of proposals that the PTAC can approve. So it's not like as if this is a competition amongst proposals.
I'm Lynn Nichols. I'm a health economist from George Mason University. I direct the Center for Health Policy Research and Ethics, and I have no conflicts.
I'm Grace Terrell. I'm a practicing general internist at Cornerstone Healthcare, a multi-specialty medical practice in North Carolina. I'm on the board of a population health management company called CHESS, and I'm the chief executive officer of a biotechnology company called Envision Genomics in Huntsville, Alabama. No disclosures.
I'm Bruce Steinwald. I have an independent consulting practice in healthcare financing and Medicare issues. I'm a former government official in numerous positions, and I have no conflicts.
I'm Ann Page. I'm staff in the Office of the Assistant Secretary for Planning and Evaluation, PTAC staff, and also the designated federal officer for this VACA committee.
And I'm Mary Ellen Stallman, also with the Assistant Secretary for Planning and Evaluation. I'm the staff director for the PTAC staff supporting the committee.
Thank you. We are now going to turn the meeting over to Len Nichols, who is the lead for the PRT for the COPD and asthma monitoring project.
Thanks, Jeff. I would like to call attention to the lead slide there and remind everybody I stand on the shoulders of giants with Dr. Tim Ferris and Dr. Grace Terrell. I don't know how a non-economist got in charge of this, but hey, it's America. It's an interesting country. We'll do the best we can. And maybe even this will work. I'm supposed to click to the right. Do I point this to the sky? Yeah. See, I told you we should have had a docking charge of this. This would work better.
Sometimes I have an extra one.
Yeah, they probably got it switched off. I think it worked well. I don't know if it worked. We could probably find a human do it by hand if we had to, I would guess.
We could. That's why they have technical in, the name, in our name, right?
Oh, look at here. Progress is being made. Thank you so much. So I'm going to briefly review the PRT's role. I'm going to talk about the proposal in general, a summary of our review and some of the key issues, and we'll talk through then the evaluation. Basically, the way the process works is a proposal comes in after a letter of intent has indicated a proposal is coming. The chair and vice chair of PTAC will assign 3 members to serve as a preliminary review team, and one of those members is tapped to serve as lead reviewer. Basically, the first thing we do is read the proposal and make sure that we have the information we think we need, and that includes both questions to the submitter, and I would like to commend the submitter for the response to our questions, which were quite voluminous, and your answers were very good, And we also turned to ASPE staff and some of their contractors to get more information. After we review the proposal, we get all the information and so forth, and as you probably know, public comments are available at all these stages. They see the LOI, they see the proposal, they see the comments. We prepare a report of our findings to the full PTAC. That report is posted on the website 2 weeks prior to this committee meeting, and it's important to reemphasize, as Jeff did at the outset, that PRT report is not binding. PTAC may reach different conclusions. In fact, members of the PRT may reach different conclusions. We're free to do that as we deliberate and discuss things with our colleagues going forward. I will also say, since the PTAC report became public, the submitters filed a statement in response to that, which I found insightful, but I think not everybody had a chance to read it before today, but I'm pretty sure my PRT members are reading it as I talk, so we'll keep going here. Okay. The intervention in general is to look for COPD and asthma beneficiaries, and they would receive a Bluetooth peak flow meter and some software tools to permit data to go to a central server, which through monitoring and management could trigger clinical interventions to reduce early exacerbation and respond quickly to infection detection so that we could accomplish improvements in quality of life as well as lower costs. The payment model calls for CMS to pay for the flow meters, to pay an inflation-adjusted per beneficiary per month remote monitoring and management fee, to waive copays for beneficiary access to the services, allow collaborating pharmaceutical and device companies to provide beneficiaries with discount pricing and coupons for drugs or equipment that may be prescribed to control their particular pulmonary conditions. The proposal aims to improve the health of patients, reduce avoidable ED visits and inpatient hospitalizations. Reductions in emergency department and inpatient utilization are expected to offset the cost of the intervention and thereby lower the total cost of care. And the submitter expects to reduce mortality as well. Let me briefly review our preliminary judgments of each of the 10 criteria as specified by the Secretary in the final rule. And you can see pretty quickly, if you just scan through there, they meet criterion on 8 of the 10. On scope, we definitely think they did. We'll go through these in general. You see there are 2 where we did not meet the criteria. We didn't think it met the criterion. The first, a high priority item, is the payment methodology specifics, and then integration and care coordination. We didn't think it met criterion. We were unanimous in all decisions except for 1 on flexibility. We had 2 vote one way and one another, but in general, the conclusion was it met the criterion by a majority vote. The key issues that we identified, basically, there's no question, this is a very high priority issue for CMS. There are a lot of patients with COPD and asthma, and the framework the submitter has proposed, we think, has great merit, and I think it's fair to say we would like this to be a successful payment methodology going forward. We do think, however, there are elements of this proposal that require further development, and that's why we raised the concerns that we did. Our first concern, which was clear from the way the documents were presented, there were no quality performance requirements to earn shared savings. In the letter that I talked about that was submitted after the PRT report became public, the submitter has indicated there are some quality metrics which I'd be happy to connect, and we'll talk about that today as we go forward. Do all of the PTAC members have that response? I think it was handed out in paper before. Yeah, okay. It was electronically sent, but there were a lot of things sent, so not everybody caught it. The model does not count some real cost, such as Part D spending and waiving of copays, and we can talk about that as well. The risk adjustment was the thing that probably concerned me as an economist the most. It was the proposal was based upon a number of chronic conditions the patient has. This method has not been tested, and frankly, I think it would be too risky to put a risk adjustment regime in place like this, but we do think we can talk about how to modify that over time. And then the clinical concern was mostly that the model didn't seem to have enough detail about how integration would be achieved. Primary care providers would not share in the financial risk or the incentives of the program, and other providers behind the pulmonary subspecialist were not clearly integrated with the care delivery model as well. So now I'll go through each specific criteria and what our assessment of it was, and where I think it's important, I'll bring in what the response of the submitter was, and then we'll go from there. So the proposal, as I said, aims to care for patients with COPD and asthma to well-defined and clinically important conditions, roughly 5.4 million Medicare beneficiaries with either COPD or asthma or both. The proposal would cover the daily monitoring. It would utilize new technology, have two-sided risk, a lot of good features we want. It would certainly broaden CMS's alternative payment model portfolio by including pulmonary physicians who are not participants in existing APMs, and of course it would be a large scope because of the size of the Medicare population. The initial proposal is for 2,000 beneficiary pilot, but it could be scaled up over time. So in our view, there was no question this met the scope criterion. The second criterion is quality and high priority. And here I think it's important to pay attention to specific words. We do believe it meets a criterion, but I think it's fair to say we think it minimally met the criterion. There is considerable literature that investment in programs that enroll well-selected patients with chronic conditions characterized by frequent exacerbations resulting in hospitalization can effectively improve quality and cost. However, for this particular kind of intervention, there's really only one study with sufficient N to give us confidence. That study was conducted in Germany, where a few things are different. They have better beer. They also have different prices of devices. And we didn't think that there was enough detail specified, and we can go through the details of that, but many of the clinical details remain to be worked out. However, we thought the promise of the intervention and the plan of the submitter was sufficient to say it met the criteria, assuming the other criterion were met. We didn't want this to be the stumbling block to success. The payment methodology is the place where we felt like there were questions that needed to be answered before we would recommend going forward. Let's remember the basic approach. There will be a PM-PM payment and a shared two-sided risk arrangement, and that certainly seems appropriate for this kind of clinical intervention, but there are too many unspecified or questionable features. I said in the proposal there were no quality performance requirements linked to earn shared savings. In the response to the PRT report, the submitter identifies a number of quality metrics, which I will leave to my physician colleagues to discuss when we get to that. The model does not count some real costs, such as Part D spending, which was a concern. I think we can talk about that when the submitter gets to talk, and we'll have a back and forth. But one issue that was clear to us, at least in the way we interpreted the proposal, was that the model would waive the copays for the beneficiaries in the project, and that we were afraid those costs did not count in the way they described the model. In the response to us, they said, oh yes, we meant those costs to count. So I think there was confusion about whether those costs should count against Medicare savings. And so fundamentally, they would have to be made up in order for the submitter to win a bonus, and that's important to understand. Risk adjustment was the bigger issue, at least again in my mind, and I think in our collective minds, because, you know, and I think it's fair to say, Mr. Chairman, that this group suffers from the same problem everybody else suffers from. They don't have access to the great data that would enable them to develop a more fleshed out risk adjustment model, so they proposed using number of chronic conditions, which given the data they had was a reasonable first step. Our concern is that that has not been tested. Our concern is there may be much better ways to do it if they had access to good Medicare data, and that's precisely the kind of technical assistance we would like to make sure this submitter and others have access to at some point. The per beneficiary per month amount was not based on the cost to provide these services. It was based upon a sort of a adjustment given a number that had been worked out for, I think, cancer care or something. So that clearly needs a little bit more work. And then the cost structure that would guarantee the savings assumed device prices that were based on European pricing, which is where this thing has been done full speed before. And obviously in the United States, those prices are likely to be somewhat different than they are over there. And so for those reasons, we reached unanimous conclusion this payment methodology does not meet the criterion as laid out by the Secretary. On value over volume, we thought it certainly did. There's no question that it would enable clinicians to efficiently monitor and manage a patient population with great need, and the early detection is precisely the kind of innovation that we want physicians to bring to fruition. Flexibility, here is where we had our one non-unanimous decision. We agree about all the facts. We differ on the judgment about what to do with those facts. The proposal is simultaneously rigid and somewhat vague. There did appear to be a reliance on one specific device and data transmission method. The exact clinical protocols have not been completely worked out, and that was a concern. But I think the larger concern is that the proposal lacks sufficient detail on how the coordination with other providers would occur, given the lack of specificity of the clinical protocol. So 2 of us were willing to give the benefit of the doubt, 1 of us was not, and that's why the majority, as opposed to unanimous decision, was reached here. There's no question this thing is eminently evaluable. And here, integration and care coordination, which is somewhat related to the flexibility one, we felt unanimously that it did meet care coordination criteria, but did not meet integration. Does not describe in sufficient detail how primary care physicians will be made part of this, and does not describe really that much about ensuring that the financial benefit will flow to anybody other than the pulmonologist. So we thought there was too much unspecified about integration, and this decision was unanimous. Patient choice, the patient enrollment is optional, so it's kind of hard to argue with that. Patient safety, again, there's a lot of focus on preventing early exacerbations and infections, so we think patient safety is strongly supported. HIT, I think it's fair to say there's a lot of work to do here, because the specific software and device interfaces would need to be developed, and for those of us who've banged around these systems, that's not a simple thing. But again, we thought this is certainly all doable, and therefore we felt like the judgment was correct, that it did meet the criteria of the Secretary. So there you have it.
I want to thank you, Len, and also thank the members, Tim and Grace, for their efforts on this PRT and all the heavy lifting that they did in your analysis and summary. Thank you very much. I'd now like to ask the committee members if they have any questions for the physician review team, the proposal review team. Seeing, wait, Bob?
Yeah, I was hoping somebody else would go first. In their proposal, they say the following: based upon the review with the peak flow meter findings, et cetera, any recommendations for medication change will be sent to the primary care provider, or alternatively, if the PCP allows, the pulmonary specialist at camp will make these changes, and they will be recorded in the patient's EMR. Did the PRT pursue this at all to determine accountability for the patient's well-being? I mean, that's a concern I have, and in the questions I didn't sort of see anything additional to sort of find out how this would work. I mean, I could imagine responsibility falling through the cracks in this kind of a situation.
We agree, and that was precisely why we the integration. We did not. There was not an explicit plan for the integration of care between multiple providers. Most patients with COPD don't just have COPD, so it's not only the primary care provider for whom this specific question you asked, Bob, but also other specialists. It's very frequent to have cardiac disease. It's very frequent to have COPD patients to have a cardiologist. So the proposal, I think it's fair to characterize the proposal as being fairly robust in the specific area of care for patients with COPD and asthma, but much more limited in its description of how you provide in this model patient-centered care that involves the integration of all the other physicians who are taking care of the patient.
I mean, this, I guess I could reserve it for later, but in the clarifying letter, which is a helpful letter, in the current model, we envision using medical assistants supported by pulmonary nurses, IT software engineer, 2 nurse case managers, a behavioral psychologist, a respiratory therapist, a statistician, and a medical director, but no pulmonologists are mentioned, and it seems like it's not a physician-focused payment model. It seems to me it's disease management support, and that's one of my concerns about it. I will mention some others when we get to the later discussion.
Please,
I think, so because of where the proposal is coming from, I think that we gave the proposer the benefit of the doubt that this was pulmonology focused, since that was the ostensible platform on which this is working. And I would say that the team of people identified in that list is precisely the kind of practicing at the top of your license, have the real work done by physicians, and have the constant contact associated with either monitoring systems through IT or outreach to patients that helps stave off remediable exacerbations. That's precisely the kind of team that one might put together to enable that kind of performance. So I think while I agree with you, it's not explicit, I think we read it as part of a whole in this setting.
Well, Harold?
This, I guess, is somewhat related to the question Bob raised, but the issue that this is also related to the proposal yesterday. So we have an applicant who is in fact a physician practice who has a particular approach to changing care. In this particular case, wanting to use Bluetooth monitors and respiratory techs, et cetera, et cetera, et cetera. But the payment model, if I understand it correctly, is to pay a per beneficiary per month payment. It is not specifically to pay for Bluetooth monitors or to pay for respiratory techs. And if this particular practice would choose to use the PBPM in that way, that would be their choice. But if the payment model is a PBPM, then some other practice could choose differently to be able to do that and would then be accountable for the outcomes. So I just wanted to, and I'll ask the applicant this too, but was your understanding of the model that it was to give the practice a per beneficiary per month payment, and then they could decide, whoever got it, could decide what to do with it? Or was the payment model to pay them specifically for this particular defined technology and intervention?
So part of the payment model was to provide the Bluetooth meter to the patient. So that's a given. The technology is a given. And the PMPM was to provide the resources for the team that Bob just articulated, in addition to the pulmonologist, to manage those patients.
Right, because there were two pieces of payment.
Certainly, and there's also a third here, because there's a shared savings component against the target spend.
But the PBPM would not be tied to a specific structure of care delivery.
That was not my understanding.
Okay.
It would be flexible from the clinician's point.
Although there was some, in the questions, some discussion of particular algorithms that they had developed or would develop with respect to how the the management of these patients would proceed with the team that they were involved with. So whether it was a specific algorithm or care pathway or another or some other way, or whether there was flexibility in the model, I think your questions, both of you, are getting at how much of this is prescribed is a good one. There was work that was alluded to with respect to the fact that they've had some of this flushed out and have developed algorithms in place that were particularly tied to a care pathway. This gets back to what we talked about a little bit, I think, yesterday with respect to care models versus payment models, and the concern that I expressed then that this is going to continue to be the thing that we've got to understand, the relationship between the two. So I think your question is a good one.
Well, and particularly when we have a practice with a particular approach coming in and saying the payment model would allow this, but the payment model then would also potentially allow other things, which is and that's one of the issues on the flexibility is there the flexibility to do it differently, or does the payment require use of that algorithm, and does the payment require this particular staffing structure?
And the other side of that, from my point of view, is you really have to have very robust quality and outcomes measures as part of a payment model if there's flexibility in what it pays for. And in the supplementary information that we received that you all have in front of you on paper today, we're seeing some of those outcomes measures laid out, hospitalization, ED visits, and all of that. But the real need in a situation where there is flexibility and some people could potentially use it for other ways of doing care management has to be around very, very vigorous outcomes measures, in my opinion.
Elizabeth, your question links to Harold's.
Yeah, thank you. I think it's actually very similar, but I just wanted to get a little bit more precise. So, because we're talking about a specific product, and as we talked about yesterday, that might not always work in some practices. So you say that this same model could work if another product offered the same functionality. So you could endorse the model without endorsing the specific product?
Yeah, that was a concern we had when the proposal came. And in fact, when the proposal came at that time, the device had not yet received FDA approval, which even made me nervous, right? But we asked CMS about this notion of having one particular supplier of a given commodity, whether or not it had FDA approval. And they said, well, you know, in certain circumstances we could work it out. And they sort of implied it really depends a lot on what kind of price they're going to charge and other things. Since then, in the communication we got after our PRT report was posted on the website, it's clear that the submitter understands and would like us to understand you could use different technologies to do that. You don't have to have that one machine. And by the way, it has now gotten FDA approval. So,
thank you.
But yes, you could use different.
Yep, also please, respond, Tim. Just to add on to that, I think maybe building on Grace's comments about the care model and the payment model dynamic that I think we saw yesterday and we're going to see more of. You know, it's fairly easy for someone to propose, a physician to propose, or a group to propose, just give me a fee and I'll figure it out. Put me at risk and I'll figure it out. And that's the payment model, right? Having the submitter specifically explain what they're going to do lends credibility to the proposal, or not if what they propose to do doesn't seem credible. But having the care model, so the application appears to present us with very specific, like we will use this Bluetooth thing. I think when you think about the payment model, I'm reading the application as this is a credible or not credible clinical intervention that is going to provide greater outreach for a group of unstable patients, and that's going to reduce their rate of hospitalizations. But once you propose that, I don't feel, when I'm evaluating the payment model, like I'm tied to the very specific care model that they propose, because that care model works in that practice and in that situation. And so specifics on the care model are important, but not determinative of whether or not the payment model is a viable payment model. That's just sort of the way I'm thinking about it.
Thank you, Tim. Kavita?
So I'm going to ask questions to the PRT, but I found also that it might be helpful to hear what Jeff and Elizabeth think. I'm struggling a bit what to do because it does seem like the responses clarify some of the issues specifically around the quality metrics, cost metrics, and that may or may not, I mean, for me, it at least changes a little bit on kind of how I think about that section on quality cost and potentially the value volume question. So I'm not sure, kind of I'm out loud kind of questioning, you know, do we kind of take this information and how would you kind of process responding to what I think is clarified? So that's a little bit of a process and substance question. The second question.
Well, let's just get one at a time. How about that? Okay.
All right.
So, because I think that's a very important place to start. Because let me just say, this is why I'm glad I'm not a doc. I think that Tim and Grace should respond first, but all of you should talk about the proposed quality metric. Because we saw the absence of that in the response letter you just saw. They said, oops, we meant to include it, you know, whatever. So here we are. So I think you should look at it specifically and draw your own conclusions, and I'll be glad to learn from your thoughts.
Tim?
Oh, go ahead.
Well, I guess, Kavita, well, I too found the responses very helpful, and they now put us in the realm of plausibility, but they actually don't tie, there's no formula to tie them, and as we know, tying them to the model is actually a non-trivial exercise. So it is, what I would say is it's very helpful and directionally appropriate, but I'm still not sure that the response constitutes a payment model, at least in a payment model insofar as it is specifically evaluable. Like I still can't say, would this work or not, because there's no math there there's no formula.
Kavita, also embedded in your question was a process issue. We have spent considerable effort lining up the evaluation, communicating with the submitter, working with the proposal review team, drafting the recommendations. A lot of distillation of information has occurred. And again, we operate transparently, and we want to have the back and forth with our submitters and our stakeholders. Everything is put out for public comment. That's the other thing that is digested by the proposal review team. Our challenge, and this is really not specific to this proposal, is that as a committee, when you get a 6 or 7 page letter with exactly the kinds of information that will help us sharpen our thinking on this proposal, the timing makes it very challenging for us as a committee to digest this information thoughtfully and then be able to have a rich deliberation as you see playing out before you this morning. That's a challenge, that's a process challenge, and I don't profess to be able to solve that today, but that is something that we're going to have to address going forward, because we've had, you know, it's not just this proposal, but we have a similar circumstance with some of the other proposals as well. Harold and then Grace. Yeah, I just
well,
saw.
I think it would be good just to spend a minute on this, just to build on Jeff's invitation to people who are listening to send us suggestions about how we might improve our process, because it seems to me that there's at least 3 options one might do to address this. One is that the PRT report, the draft PRT report, needs to come out farther in advance of the meeting, which would then give people an opportunity to respond to it and then to have it potentially revised, but that would delay the process. Second option would be to have a process for tabling something at a meeting and saying we can't make a decision today because the new information that we've gotten is more significant, or to have some kind of a rapid revision, resubmission, and review process afterwards, so people don't sort of get a no and then have to completely start all over again. And I'm not sure at all which of those is the right approach to use, and it would be, to me, useful to hear from, people who are thinking about this and watching the process, kind of what their reactions are, so that as we consider the options, we could take that into account.
Grace, and then Len.
One of the issues, therefore, is the process we have of our review adequate or not to where these things could have been put forth earlier. So, I mean, you can question this for any of the reviews, to the one later this afternoon, this one, or the one yesterday was, well, why are we getting information at the last minute or later than the sort of the process that may be changing our mind or allowing us to have a richer set of things. We set the process up with 20 pages only, so that we wouldn't get hundreds of pages of stuff that wouldn't necessarily get us to where we needed to go. And then we have a review of that information, research that we do, and then we have a series of questions back and forth. And I've participated in 2 of these now, and they've been based on some free-form conversation between the members of the PRT saying, well, I've been thinking about this, and you've been thinking about this, and developing series of questions, some of which were, 39, 40 questions, of which we got very good answers back. But maybe that's really a problem in the process right there. That needs to happen, and then there needs to be something much more specified that would get there. I don't know, but it would seem to me that as we're evaluating this one in front of us now, we based our initial assessment and reports on the information that we had after going through that process. And then we've got other information here, just like we did yesterday, that elaborates on that. I'm not sure that's a bad thing. It could potentially always happen, but simply because you learn as you go along. But whether this changes the outcome today or not really is going to depend on as we go through the rest of this process. It doesn't, I believe, eliminate the essential problem we saw with this particular proposal, and that is they needed help that we weren't able to give them because of the constraints we're under. And that is, had they had some ability to understand, had some technical help that would have allowed them to maybe flush through some of the issues with respect to the payment model particulars that we then critiqued them for, it could have made it stronger. That's what we've got to get better at. This is a good example of a proposal that has some very, very, very good things. We desperately need in this country ways of providing better care to COPD patients. That is probably several types of innovative care models linked to payment methodology that will allow physicians to do that. But the actual details that they needed to get there, as we've talked about earlier this morning, were not part of our process, and we weren't able to help them do that, as you know. So.
Len?
So I would just pick up on Grace. I think, in fact, this is working. Yeah. I sort of don't think that we need to necessarily change it. I'm not sure. I'm convinced it's broken. What I think has happened is that we got the proposal. We asked a bunch of questions. They answered the questions. We asked questions of a professional who know more about data than we do. We thought about it. We wrote the PRT report. I think the PRT report, if you will, sharpened the mind of the applicant in a way. Okay, that's what they're worried about. Boom, boom, boom. This thing right here is a good piece of information. I don't think it came too late for us to be able to think about it. It did come in email. It's just that I don't think everybody on the committee got that email. I think that's where we are. And so, to me, this is the way it should work. I totally agree with Harold. If the information was sufficiently game-changing, I might want to table. But I don't feel like that's required today, given everything else that we've got. So in some ways, the only thing I would suggest we change in the process, and I think this might have been proposed at one point. I'm looking at Mary Ellen because you probably thought of it and we probably nixed it. Maybe we should send the PRT report to the submitter before we go public and have a little more time, one more round of back and forth. I think my concern was, oh my God, that'll delay it. But if these guys respond as fast as this man did, I don't think we got a real problem with delay. So I think maybe we should reconsider that.
I want to make sure, Kavita, you have another section to your question, but I think Paul, if you're going to respond to the original process.
Yeah, this will
and
be
Elizabeth,
quick, and
yeah.
I'm sort of with Len. I mean, I don't think that it's really very broken. I mean, at some point, you put out the report, you're going to get a response. I mean, it's just going to, we've seen it, all three. We've gotten responses organically from all three. And I think really whether we send it to them earlier, et cetera, but I think we need to receive it earlier, you know, as a full committee, to be honest with you. And I don't think, you know, if I had it a week ahead, would be fine. And I just want to emphasize.
Well, to be fair, it did come in an email, and I
Right.
saw it, and Mary Ellen called my attention to it,
Right.
and I said, that's interesting. I'll read that next week when we get there.
Right. And I guess the other point to underline is this is the preliminary report, and I think preliminary is okay. I mean, you know, and again, it doesn't have to be perfect and have everything when we get here. Just 2 points.
Thank you, Paul. And Elizabeth?
Yeah, just a quick additional comment. I'm associating myself with Len. The entire intent of this public forum is to get additional information, and I think we are genuinely committed to incorporating that to the extent possible. I'm relying on my colleagues to help sort of evaluate, do these new metrics make a difference in your initial assessment? But it might be hard to watch, but we really are deliberating in real time, and I think additional information is really an aim of that.
Thank you. Kavita.
Oh, so I had kind of a second set of questions around kind of the PRT's reaction, and I know there's some kind of mention to it around the risk adjustment. So if I look at your PRT recommendations, and even aside from your recommendations, kind of go through each of the criteria, thinking through that, and we'll vote on that, I still find myself kind of hung up on, I found myself kind of troubled by the risk adjustment kind of, or it's on one hand very novel, because they made a very interesting argument about kind of using the number of conditions. We know that using HCC, we know that there are a lot of flaws in current risk adjustment methodology to explain kind of the clinical variance. But my question to you all was how much of that was a discussion around specifically that section. You reference it in your summary of the PRT kind of section, Len, but I'm just, and especially now seeing the response from the submitter. And then I will say, I agree with Gray, and then the kind of a related question is how much of this tension of you know, this is a very highly, unlike the conversation we had yesterday, this is an incredibly prevalent disease, an incredible opportunity to reduce hospitalizations, ED visits. We now see that they're actually thinking about those quality metrics as part of the response. So tell me a little bit about the struggle to think about, or did the kind of sense of prevalence or impact that this could have on a very kind of burdensome condition kind of come up? So that, and then I'm done. Those are the two questions.
I just have a quick technical point in relate. You know, because of work that my organization has done in this same area, including developing care models in COPD, we did not have I did not feel compelled to have a lot of discussions about that, because one of our criteria were Charlson scores, or basically identifying people who had 5 or more chronic diseases as being in and of itself a risk model. So getting in the details from them of those stuff that I guess I already assumed was knowledge I had from my own experience, there was not a lot of dialogue back and forth. That may well have been an error on my part or our part, but it was, you know, the risk adjustment that there is data out there that you can use number of chronic conditions, with an N of 5 being the number that seems to be a cutoff for levels of stronger development of care models. So you can have 5 stable chronic diseases and 1 bad one, COPD or whatever, and that in and of itself can be for those that don't have fancy data, EMRs, you know, any other types of things, including registries that many sophisticated groups have. You can do that with a relatively simple practice criteria to the Secretary's point earlier about smaller practices or rural practices. That's one thing that's a very simple way of sometimes doing some of this.
So you saw that as a plus? I just
I
want to
saw
make
it
sure,
as a
because I know
plus.
that in your submitters, I couldn't.
We didn't have that dialogue. I had that dialogue in my own head.
Because I couldn't tell from the questioning back and forth
Yeah,
if you thought
there
that
was
a
not the questioning
detractor
back and forth.
or
but,
okay, all right,
because
great.
I was making some
So-
a priori assumptions.
So that would actually indicate that this has a novel aspect to it that's not incorporated in any other current payment methodology, just to clarify. Okay.
Oh, I think it's very creative. I think unambiguously in favor of giving them the technical assistance we think they need to get to the promised land. I will point out that the letter that came around in email said they agreed with our assessment of the number of chronic conditions. A letter that came more recently did not. Well, I'm confused too, because I thought this was a printed version of what came in the email, but this is a different letter. Okay, so there are some differences of opinion, and we probably should just table that. I would just say, in my mind, I'm still not in favor of chronic conditions, but go ahead.
Well,
Tim?
I did want to say that, hearkening back to our discussion yesterday about what might work for one group and what one group is willing to do, our job is actually to think about the implications of a model generalized. And again, it's novel, it's really interesting. There are risk adjustment methods where you simply count conditions. But in this particular setting and in this particular model, this has not been tested. And I would say to base the financial future of a group of physicians on a risk-adjusted model that there is no empirical experience with is a risky thing to do. And that is where it sort of fell down for me.
Kavita, are you? Yeah. Okay, very good. Any other questions from the committee? Well, then at this time, I'd like to invite Dr. Akeda up to the microphone, and please introduce yourself for your remarks, which will be in 10 minutes. Thank you.
Thank you very much. Press the button.
There you go. You're good.
Thank you very much. My name is Daniel Ikeda, and I'm a physician from Sacramento, California in private practice. I am boarded in pulmonary medicine, infectious diseases, and critical care medicine. I belong to a multi-pulmonary and infectious disease group in Sacramento in private practice. We have about 25 of us. And we operate both in an office-based practice as well as act as intensivists in multiple hospitals in the Sacramento area. And so when we looked at the changes in MACRA, one of the things that we were anxious to look at is a way to use telemedicine in order to achieve the 6 goals that Dr. Price had talked about. You know, we've been very experienced in telemedicine in the intensive care unit. We're one of probably the beta site for the VisiQ EICU back in 2003. And through that experience, really got a feeling as to what telemedicine has to offer medicine in general. Not only are we able to use a single physician to multiple hospitals for acute interventions, but the data repository developed through this system allowed us to actually look at outcomes, to create pilots on various papers or ideas, and to see whether or not we can validate these very different things. You know, early work in sepsis allowed us to reduce mortality from 40% to 28% in a matter of months. And we're able to use that experience to then apply protocols throughout the city to achieve similar results. And as we come to look at COPD, the problem with COPD in the clinical practice is that it's a difficult disease to manage. And the problem with the expertise in the area is that much of us as pulmonary physicians are really drawn more toward a hospital-based practice. You know, currently I spend a week a month in the office because all the priorities for my expertise is in the hospital. And clearly, there is a need out there for better monitoring and management of these sick patient populations. Now, in looking at this project, I mean, I figure when you create a proposal, you ask for everything you want with the expectation you're going to get pushback. And that's why I'm here. But, but I didn't know how else to write the proposal. But clearly, the one thing I do want to talk about is the risk adjustment methodology. You know, part of doing risk adjustments, especially when we're willing to take risk, is looking at what are current models of risk-based treatments. And you look at, you know, history of capitation, you know, it's all generally based upon a benchmark based typically on a mean, and the goal is to improve financial outcomes based upon that mean. Now, the problem with that is that in the past, you know, these types of plans are subject to cherry picking. In other words, if you can get a population of low-risk patients and skew your distribution curve to that side, your numbers are going to look great, but you don't necessarily provide the care that you really want to do. So, for instance, in COPD, and having access to the chronic condition database, which appeared to be very robust and stable based upon just looking at averages over years, it provided us at least a thought of an opportunity to see if we can actually develop a capitation model that doesn't reward cherry picking. Because if you think about how this would work under a classic condition, you know, as part of the evaluation, somebody created brand new tables that were great. I wish I had them when I wrote the proposal. And among the comments was the fact that based upon their evaluation of the universe of COPD patients with existing COPD, which had the biggest N, the average cost of care was about $24,000. Now, when we did our proposal, we specifically removed the low-risk patients, patients with conditions 1 and 2. And by doing so, our average cost of care was $32,000. Now, it's the same population because we did the calculations both ways. And so that suggests that if this program were to go forward on a classic capitation model, then there is a risk that the whole process would fall apart because of game sharing. And that's not what our purpose was. You know, as a critical care physician, I'm very comfortable taking care of very sick patients. And it's really this population of patients in the outpatient that needs the care. In a classic capitation model, where I'm at risk for losses and wins, for every sick patient I get, I want 2 or 3 healthy patients, you know, if that's the model of capitation. But using a model that actually forms separate buckets of risk, and in this case using chronic conditions as that, and forming a mean, a median, knowing what the 99% distribution on the high side is for the fat tail, it provides us now a much better ability to skew my distribution curve toward the sickest of the population, which is the population that really needs the service, without the fear that I'm going to screw myself over because I've chosen a sicker distribution of patients. And so, as we look at the risk to me and to our group, I'm far more concerned about a risk-based model that is based upon the universe of COPD patients because, first of all, the annual cost of care is much lower. Therefore, I would have to actually improve care by a much more dramatic amount in order to achieve savings for Medicare. On the other hand, if I had a capitation model that actually looked to capitate the high-risk group at their true cost, then reductions in costs related to reductions in ED visits and hospitalizations will dramatically improve the overall cost in the high-risk group, which will be reflected in the overall cost of care based upon a comparison, an apples-to-apples comparison of distribution of, say, patients with say, 9 chronic conditions or 7 to 9 chronic conditions. You can probably lump them at that base, because in those tables, Table 1 shows that the distribution of patients from 1 to 20 actually forms a pretty good normal distribution. But obviously, the costs associated with the 0% versus the 99% are vastly different. And that's why we developed this proposal specifically looking for a model that we would be willing to take risk in. And the only model that really works is not taking care of the healthy portion of that population, because that would actually cost money to Medicare as opposed to save money to Medicare. And so that's why we developed this methodology to really address that question. And based upon that, obviously we have concerns about tail risk, you know, in this high-risk population. I don't have an answer to that except to say that as we did our per member per month fee, you know, we started first with a assumption that, well, what is a reasonable number to start working with as a benchmark? And so we went to the oncology model. And they suggested about a 6% cost increase. Now, whether that's valid or not, at least it gave us a benchmark that we can put aside and say, well, okay, for 2,000 patients, that's a revenue stream of $4.2 million, right, for our proposal. And then the question is this something we can financially do, make it valuable? But more importantly, can we create a model that is then scalable? So setting that aside, you know, we've been working on budgeting as to what we would actually need for this process. And part of that's really in the paper that I sent today, where basically, you know, outlining, you know, what our beneficiary to healthcare ratios that would be appropriate and safe, what are the supervisions, what type of ancillary health I need, setting up a new office, you know, needing healthcare consultants to help through this process of the data, which is really critical to this type of project. And, you know, our annual budget to maintain the program right now is running about $3 million proposed. Plus, there's infrastructure costs that startup that we probably will estimate at about $500,000 to $800,000. And then that leaves the remainder, which we felt in order for us to have a go at this, we would need at least a 20% revenue withhold in order to protect ourselves if the project fell apart. So we're talking $800,000 to $1 million that we would basically put in a withhold account in order to cover our downside risk. And with that, we felt we can actually do this project, you know, and accept the risks, which are still unknown to us to a great extent, but create a model by which population monitoring can now be financially viable. And that's the key. You know, that's the problem with telemedicine. There's no good financial model to make it a viable product. But if this project works, then all of a sudden it opens the door for other things. Now, regarding coordination of care, you know, when I did the proposal, I realized that if we're talking about receiving revenue for multiple chronic conditions, at some point we would have to address the other chronic conditions. And the dilemma I had in the proposal was not talking about that because I didn't want to deviate focus from the primary project. So now we're talking about, well, we can do telemonitoring for multiple chronic conditions. And in reality, that's not really what I want to do right now. I need to validate our assumptions first with what I think is the easiest of the chronic conditions to actually save Medicare money in. You know, as a 30-year expert in infectious disease and pulmonary, this type of system will recognize infections at early stage. It doesn't have to be pulmonary, it could be something else. It will recognize early exacerbations of COPD. And if we can capture that and, more importantly, train patients on a continuing interaction to recognize these things and know what to do ahead of time, we will go a long way in preventing ED visits and hospitalizations. And so I find the discussion between the care model and the reimbursement model very interesting because we struggled with that too. I mean, we want the care model, but we have to develop a reimbursement structure that would make it viable, but more importantly, if successful on a limited basis, is economically feasible to scale up. And that's the input I can give you right now. And I'm open for any other questions.
Thank you, Dr. Ikeda. Tim, you had a question, and then Bob.
Well, first, just a comment that if more physicians in the United States were so focused on the integration of a care model that is proactive and attempting to minimize the utilization of services, and at the same time so thoughtful about the payment models that are necessary to undergird and support that kind of care model, then we wouldn't have a reason for existing. Having said that, I did just want to get your take on a specific concern around the, and I'm sorry, this is going to be a little technical, but you seem to be up to it. If you simply count conditions, I'm going to read you 5 conditions for 2 different patients, chronic conditions. So the first patient, patient A, has hypertension, arthritis, gout, psoriasis, and chronic sinusitis. The second patient has heart failure, amyloidosis, stroke, coronary disease, and diabetes. Those 2 patients are not even remotely similar from either a cost or a care delivery perspective. And so while I am really excited about the novelty of the method you're proposing, I'm not sure that, given those 2 different scenarios, that there is not still an opportunity for a risk adjustment system to either be abused, which all of them do, we're not letting the perfect be the enemy of the good, or that through some random chance, the risk adjustment system actually might leave a physician's practice in the lurch due to just the variability in the selection of patients, that it was unanticipated and uncontrollable. And so I'm just wonder if you'd comment.
So what I will tell you is that obviously the two patient examples you gave me, first of all, none of them had COPD. All right. And I think that's critical, at least to this proposal.
Comorbidities. So
right.
There was an assumption that they both had
So
COPD.
everybody in my cohort of patients will have COPD or asthma as a defining condition to enter the program, because that's the area where I have the expertise to intervene. And just looking at the new data tables that came out, and I've looked at, and the one I'll reference is table 2B. So if you look at that particular table, and you look at ED visits related to COPD, hospitalizations related to COPD, there's a validation that in patients with COPD, much of their high utilization costs are due to their lung disease and not to their other comorbid diseases. And that's the disease state that I am targeting to control, and that's why I am proposing I take all this risk to prove it. Does that answer your question?
It answers the question in the sense that you, because of who you are and what you're committed to, are willing to take on the risk, but it does not answer the question of whether or not either the system is gameable or that it could result in adverse financial consequences to any specific practice given a uncontrollable risk selection.
So I presume we'll be a guinea pig.
I'm sorry?
I presume we'll be a guinea pig.
Yeah. Thank you. Bob?
So let me start by saying that I'm very sympathetic to what you're trying to accomplish here. I have a family member who wound up on a ventilator 2 consecutive winters for weeks at a time because early symptoms were ignored, and that's what happened. So I'm all for it. But I have some concerns. So let me ask you this. You're in Sacramento. It is the heart of Medicare Advantage country. Are there Medicare Advantage plans who have been interested, or capitated medical groups, there's over 200 of them in California, that would be at risk and presumably would be quite interested in a technology that could reduce hospitalization and morbidity and mortality? So what's been the experience there?
Well, the answer is there is a great deal of interest. But the question is, at what cost and what reimbursement? That's unestablished since we really don't have, this is not a viable program as we sit here today. So, you know, part of this proposal from our minds is to establish what is a pricing model that we can use as a benchmark as we go to a Medicare Advantage plan. And I don't know what the answers are related to that, because I know what our costs are going to be, and it's not inexpensive. And so from that perspective, you know, I have two medical directors that want to talk to me, you know, after we get this process done, and we are anxious to look at that. You know, down the road, we want to treat asthma in Medi-Cal, or in Medicaid, since we're in Washington, D.C. And originally, this project was developed for, I think, the Innovation 2 grants, but I couldn't finish it in time to submit for that. I really wanted to treat a Medicaid population using this model. Obviously, since it was a grant, I didn't know what the payment model would be afterwards and whether it would be sustainable, but that's water under the bridge now. But I think that this type of care is easily replicable for Medicare Advantage plans and capitated plans. Now, whether it's designed to improve care or reduce costs is a different matter, because in each individual Medicare Advantage plan, they may not have the sufficient volume of patients in, say, COPD to make it, you know, worthwhile for us to do and for them to entertain. Although it may be very viable for them to choose high-risk patients in general and monitor them that way. But then the goals and outcomes would be different necessarily. It's not necessarily to save money. It is, in one sense it is, but really to provide better overall care, and hopefully through that process reduce the cost to Medicare, which are not as predictable as with patients with COPD.
Well, let me just follow up. I mean, my concern basically is that, well, if I were, let me just say this, if I were a Medicare Advantage chief medical officer, I would be looking for more than a German study to demonstrate the proof of the concept. I mean, this strikes me as quite relevant for clinical research to prove the effectiveness. We do know that disease management has potential negative impacts when one organization is doing the disease management and they are not integrated with the practice that's actually responsible for the patient. Those would be the kinds of questions. So I guess my question is, have you attempted or thought about the need for doing clinical research to prove that the intervention actually works to improve quality and decrease costs before trying to get a national payment model in place?
The answer is, I'm a clinician. I'm not a researcher. And through, you know, our experience with telemedicine, as well as in the practice of pulmonary medicine, we strongly believe as a group we will save money. We will prevent people like your relative from hopefully getting sick enough where he ends up intubated. I mean, I see this all the time in the intensive care unit. And when I talk to them after we've hopefully saved their life, I ask them, well, how many days of symptoms did you have before you came to the hospital? And typically there's this window of time, whether it's 2 to 5 days, where patients ignore their deteriorating symptoms and come in where it's too late to intervene at a point where they don't need to go to the ICU. If I can capture these patients early, I will prevent their hospitalization. I know that. And so based upon the studies that we have read, we've seen enough information so that we are willing to take risk on this because we firmly believe we will achieve the outcomes that will provide the 6 points that all of you are looking for in all your projects. We have that type of conviction.
Thank you. Harold?
Thanks, and thank you for doing all this work. I agree with Tim that this is the kind of thing that we hopefully will be encouraging. I had, I guess, 3 questions. The first one, in some ways, is related to the question that Bob was raising, which is that if I understand the proposal correctly, the physicians in your group would not actually ever see the patients in person. You can clarify if I'm wrong about any of this. And that there would be basically a remote monitoring to support other physicians, primary care physicians or otherwise, who are the primary care managers for the patient. And most of the, as Bob was referencing, the experiences with care management programs have shown that unless there is some direct patient contact, at least for a portion of the time, not totally, and that there is some real involvement of the patient's primary physician who's managing the condition, that the results are less successful. I have my own personal experience having run a project like this, which is getting the primary care physician or whoever is managing the patient to be engaged with the patient, to have them accept that this thing that they're participating in is helpful, is important. So I wasn't quite sure that I understood exactly in reading the proposal how you envisioned that connection sort of from the patient's perspective working. So someone is helping them manage their COPD or asthma, you're helping them manage that. And how would this appear from the patient's perspective, and how would the patient feel like there was really a team working together to support them?
Those are all very good questions.
Thank you.
What I will tell you is that everything we envision, looks at these issues. The reality of what we actually are going to do still is in flux, because I don't have a specific answer for you. What we envision, though, is that as patients become linked through us through this daily interaction, what we hope to happen is that they will call us first if they think they're in trouble. And based upon that call, we can intervene initially remotely with maybe hourly or daily follow-up to ensure that they are not getting worse. And if they are not getting worse, we will plan to see the patients if they're locally. Now, as we go to a more scaled issue, that's going to be much more difficult. But that's why I believe in scaling, it will require a consortium of physicians to really take over that portion, that role. I think that what this continuous interactive monitoring will do behaviorally is really try to reset behavior, to make patients, adherent to a certain time of day doing certain functions, becoming more educated and empowered to recognize their symptoms, to take presumptive action given a specific set of rules, and to call us to let us know what's going on so that we can make sure they've made good decisions. And if they're not doing better, to get them to an appropriate health care provider immediately so that they don't end up in the emergency room. And if that health care provider is us, then that's what we're committed to do.
That all makes perfect sense to me, and I have seen that in action. The challenge I'm talking about is how to actually get the patient started in that process, to actually be, because I've seen the problem that patients have had enough of yet another person being involved. So I guess I would just suggest that I think that sort of how do you get the patient engaged and how do you have the PCP engage the patient is important. Second question I wanted to ask is, if I understand it correctly, again, you're proposing a flat per beneficiary per month payment, and the risk adjustment would apply to the spending target, even though it would seem to me that the patients who have more needs and more diseases are in fact going to take more time. And so I wonder if you think there is still a potential for a cherry picking problem with a flat PBPM.
I don't know the answer to that. I presume that as patients have many more chronic conditions, that bucket mean cost will be much higher than somebody with 3 less chronic conditions. Obviously, that sicker patient will have a higher likelihood of going to the ED and being hospitalized. And yes, they will require more time, but really, that's the patient that needs the time. That's why when we look at ratios of providers to patients, we'll get a sense as to who the patient populations are at highest risk of having problems. And I can't tell you we have processes for that right now because we don't. But clearly, if we can identify a cohort of subset of that patient that we can briefly say they're going to be in the hospital in the next 3 months unless we change things, then it's imperative on our part, even if only from a financial point of view, to create a treatment plan designed to attack this in conjunction with the primary care provider. Because many of the problems that we may face, and I expect to face, will be non-pulmonary. And we have to acknowledge that we will play a role in that intervention to get the patient to the right provider.
But I am accurate that you're proposing a flat per beneficiary per month payment,
that is
not
correct.
A risk-adjusted payment. And the third question, which I was convinced that Bob was going to ask, but he didn't, was, and probably will if I don't, is COPD and asthma are both underdiagnosed and misdiagnosed conditions. And I wonder what you have thought. So again, in a model like this, all of a sudden, the payment is based on the patient having the condition rather than a particular service being performed. And I wonder if you've thought about, particularly again, given your, in a sense, distance from the patient, that you won't actually, if I understand again correctly, have seen the patient yourselves and diagnosed the patient, whether you've thought about what problems that might create and whether there are ways to address that.
Well, I think part of it is patient selection, correct? And that's really what you're pointing to. We foresee starting the project, initially looking at our own patient population to see how many chronic conditions they have and whether or not they would fit a program like this. We envision that many of the patients that we try to enroll into this program will be patients who actually are captured through their ED visit and hospitalization. And so, given meeting that gold standard of having disease sick enough to be treated in an ED and hospital kind of skews the population more toward the more at-risk side than to the healthy side.
Well, potentially. I guess it does get still the issue of how good the risk adjustment is. But I just want to make sure I'm understanding this correctly. But I thought when I read your proposal, you were talking about providing this support for a broad regional range of practices. This is not essentially we are a pulmonary medicine practice and we want to have this service for the patients that we manage completely ourselves, sort of a specialty medical home concept. This is the concept where you would be providing a supplemental special service for others who are managing it. So the point is you would not necessarily have been seeing these patients. You would only see them after something bad happened, potentially. Correct. And even, I'm not even clear on whether then you would see them because they might end up at a hospital that you don't staff.
That is correct.
Okay.
So I don't know what happens when it scales, when we go beyond areas that we physically can service. And to that extent, I am kind of trusting the database because I figure the database is going to be the same either way as patients become more remote to us physically. that people all of a sudden aren't going to come up with new diagnosis of COPD in order to get into the program if they live, 90 miles away. At least that's my assumption.
Kavita, and then Bruce.
Dr. Akaitis, I first wanted to commend you because I can only imagine, it seems like your imprint is all over this proposal. I can't imagine how in private practice and what sounds like a very typical busy practice, you actually had the time to pull this together. So I wanted to just tell you that I could never have done that, and I'm impressed. I wanted to ask kind of two you've seen now the communication kind of back and forth, and it seems like there's some kind of questions about, how, even with your thoughtful response about the quality metrics, kind of how you're thinking about maybe tying that to the payment model. I respect that your day job is to actually take care of patients, so you don't study payment models on a daily basis. But do you mind just, having heard that critique, can you articulate how you may have thought about the linkage in quality with what you're proposing? And then my second question, that was just the first one.
Okay.
The second question ties to what Harold mentioned about the diagnosis issue.
Right.
Because as an internist, we know that so many people are misdiagnosed, probably by my own hands. And so there's a reliance on your ability to do kind of thoughtful pulmonary function testing, et cetera. In whether it's the German study or other studies, have you seen some kind of requirement or criteria that has like a documented basis for the diagnosis?
Well, most of the studies, don't talk about chronic conditions, number one.
Right.
They talk about COPD.
Right.
And most of their entry criteria are based upon spirometry data. Now, as it turns out, these new peak flow meters are actually have spirometry capabilities. And so, looking, and that's why we chose that, because number one, it would meet PQRS standards daily. And we'd be able to evaluate that to determine if in fact we thought patients were misdiagnosed based upon that data. That's not great, but at least it gives us more information to deal with. That's that question. Regarding the first question, as providers of care in our telemedicine unit in the ICU, we have been dealing with quality standards and metrics for the past 13 years. And typically our reimbursement for our services are tied to meeting certain benchmarks in those quality standards. So we don't have a problem being benchmarked to quality standards and attempting to meet those goals. I guess the question is what are the important quality standards of the person paying me, and what do they want? Because I can propose a list of different quality standards, and they may not have an interest in those, maybe because I can achieve them so readily. And I'm more than happy to ask the payer, what are your quality standards and what benchmarks do you want to hold us to? And I'm perfectly happy doing that. We're very comfortable with that process.
Do you mind, just, in one of your letters of support, I'm going to make sure, I was trying to flip through to find it. It looked like it was the state of California or DHS, perhaps. So you mentioned Medicaid. We have a letter of support from the state. Has there been California enjoys one of the broadest delivery system reform waivers. Was there ever a question or potential for a state of California Medicaid level pilot, or a, kind of building Bob talked about MA. I'm just curious if that came up.
Well, they were really interested in us getting the grant.
You mean getting this to work?
Getting the grant in order to do the
or
pilot.
You mean this original CMMI grant that you had applied for?
No, for the Innovation 2 grant.
Innovation
yes,
2. Okay.
right. Okay.
And so when that fell through, they were not necessarily interested in creating a funding model for it.
Okay.
Thank you. Bruce?
I'd like to follow up on one of your responses to the question raised by Dr. Ferris on risk adjustment. Clearly, that was an important issue for the preliminary review team. I want to make sure I got this right. When Dr. Ferris identified these two very disparate patients with 5 chronic comorbidities, and you agreed that they were very different, but I think you said because they all have COPD, and COPD tends to dominate the costliness of the patient, you weren't so concerned that those comorbidities were very different from each other. Do I have that right? And if I do, could you remind us on what basis do you make that assertion that it's the lung disease that really dominates the patient's costliness?
Well, I have to look at the data. I mean, the data with COPD as a primary or secondary condition, dominates ED and hospital admissions. At least looking at the data that was provided to the team. That was our initial assumption, quite honestly, is that in patients with multiple comorbid diseases, inability to breathe is probably the single most frequent symptom forcing people to go to the emergency room. Now, inability to breathe may not be due to COPD, may be due to heart failure, but clearly that plus infection. And so based upon that, I don't really know how to control a lot of these other chronic conditions like arthritis. Clearly, I know that control of hypertension is good, but that won't necessarily be reflected in any immediate outcome benefit, And so based upon lack of information that control of other chronic diseases adversely impacts the overall cost and utilization, as long as they have COPD, that's the one variable that I propose to control. Does that make sense? Does that answer your question, I guess?
Let me follow up just for a moment. Yes, it's the one intervention that you hope to control, but it also, as I understood your response to Dr. Ferris, it also makes you more comfortable that the differences in comorbidities of different patients with COPD don't concern you that much because the COPD, lung disease, dominates, in your view, the costliness of the patient.
I guess the real answer is I don't know.
Okay.
But I am willing to find out.
Thanks.
Grace?
A series of questions, some of which are just very quick answers. First one is there's chronic care management codes that are part of the fee-for-service system now. Did you all look at those? Have you used them? If not, why not? Has there been an opportunity to think about that with respect to the processes that you're doing?
Well, I don't see that code as necessarily being applicable to telemedicine.
Okay.
Because the proposal as written is not really designed to be a chronic disease management skill, although that's incorporated into the process. If we're being paid a per member per month benefit and taking risk, I don't see why I should be charging an additional charge for chronic care management. I mean, that seems to be double dipping.
I was just looking at it as in lieu of that. In other words, right now, without this payment model, there are some other things that are out there. Are you utilizing them? And if not, why not?
Well, obviously the whole impetus for us wanting to do this project is to, look at MACRA and how as specialists we can participate in some form of advanced payment methodology that would basically allow us to get a 5% increase in our Medicare payment. Okay. That's a very big incentive for us, as it would be for any other provider that enters this program. I don't see how using the chronic care management codes achieves that goal, unless you can tell me.
Okay. my next question is, if you were wildly successful with this, you've sort of alluded to this with some of your answers to some others, and we just were able to really work this out for your group and your region, what steps would you see that we would take to make this a national payment model, given the specificity of your particular situation with your practice resources versus sort of the wild west of the entire U.S. health system? And the reason I'm getting at this, you alluded to it earlier, you wrote, I think, initially a grant proposal that you didn't get in on time.
Right.
And used that thought process to actually write a proposal for a payment model. And one of the tensions, I believe, that's going to continue to happen at the level of PTAC are folks who are thinking about their own circumstances and saying, you know, if I had this particular thing, I could really practice better medicine and achieve things that I can in the current system, versus if we looked at that, how could we roll that out above and beyond just an individual practice? And as we're thinking about that at the level of PTAC, that's one of the things that we're really working on. So any wisdom you have or any thoughts you have as to how we could go from your specific circumstance to a wider policy approach, I would be interested in hearing your thoughts.
Well, what we assumed is that if we were wildly successful, people would find out and recreate the model.
Okay.
Because the payment methodology would be there, you know, and that's part of the intent. Do I think I could provide services nationwide? No, I don't think so.
Okay.
I mean, if I can just provide it region-wide, that would be a start, and maybe we'd have some expertise at the end of this to scale up and down California and maybe some of the local states. But my expectation is the economic benefit related to this and the ability to be designated as an advanced payment methodology will attract other people once they figure out that their real risks in doing this right are small. Right now, people think I'm crazy to propose a capitation model that's based upon treating the sickest of the sick. But I do believe, and as a group we believe, that we can accomplish this goal. So I hope from that standpoint we're successful, because if we're successful, the proposed payment model is economically robust enough so that it should withstand hopefully the bad fat tail risk that it is always going to be out there, or ultimately we'll come to agreement with CMS, assuming, that's one of my questions actually, is, you know, if the proposal gets approved to pass on to the Secretary, it's really my assumption that CMS will look at the proposal and at that point start making changes to the actual implementation of the concept to an entirely different plan. And, you know, I was kind of preparing for that discussion at some point in time to see how that works. And once those particulars are worked out, then the model is then out there for other people to duplicate. And I think that's the answer I'll give you.
All right.
But I think if I am wildly successful, this will scale rapidly, because it has all the advantages that we all seek in terms of patient care outcomes, and it's financially viable for whether it's a system-wide healthcare plan to incorporate and then start using those revenues to treat their Medicaid patients, you know, in addition. Because if I am correct and we are wildly successful, I mean, that's the population I really want to treat, because there is no good payment model for that. And providing the service individually is very expensive.
A couple more questions. One of the things that's interesting about a model that's taking care of the sickest of the sick and doing it in a capitated risk point of view is related to end-of-life issues. And there's a point where integration with palliative care and not doing everything, it sometimes prevents the patient on a ventilator. How much of the model that you have here
envisions that possibility?
Yeah.
Well, it's interesting that you mentioned that. I mean, we are, one of the Innovation One projects that was completed was a project called AIM, which deals with the last life of care. Mm-hmm. And that project was performed by Sutter Health, mm-hmm. which I'm affiliated with. So I'm well aware of that process. One of my partners is certified in palliative care. And so we've talked about, to some extent, how to incorporate these concepts. Obviously, in doing so, it'll increase our mortality since in planning for end of life, we have to assume that we're actually increasing mortality over the short term, as documented by this successful study by Sutter, where they did save Medicare in that program a large sum of money. And so, obviously, we're not going to reinvent the wheel there, but intend to work with Sutter in this process.
Okay. The final question I have is respect to the quality stuff that initially we felt that your application didn't address adequately. What you've brought back to us today are quality measures that are related to utilization of services, its hospitalization and ER and all that. But one thing that's true about the pulmonary and the chest specialists is they've got very specific, more traditional guidelines with respect to quality that have to do with utilization of certain types of pharmacotherapy, long-acting beta agonists, vaccine, many other things, when to use pulmonary rehab. Is there a reason why you did not think about those as being something that should be part of this measure with respect to quality and outcomes? Is that something that you're just already doing? Is that something that the care model itself would or would not be part of? But I'm just curious about that, because those, I presume, are the things that, at least as far as we know right now, have some impact on long-term, management of COPD exacerbation.
Well, you are absolutely correct. And in fact, in the proposal, I listed that we would be using guidelines from these models. Now, whether or not Medicare would want to benchmark on compliance with these, we're perfectly open for that. Because, really benchmarking to quality goals is, in our minds, primarily the desire of the person paying us, because we want to be benchmarked to the goals they want to measure versus the goals necessarily that we want to measure.
Thank you.
Dr. Akeda, I share Dr. Patel's earlier comments and applaud your efforts, given that you're a busy critical care physician. I have a couple of questions. I don't want to get necessarily into the weeds, but you made an earlier comment about your experience with the EICU. You were one of the early adopters, or worked in a system that had adopted that. And having placed that system within a 2,000 employed physician group and 15 hospitals, I want to understand that are these initial 2,000 patients, are these your patients specifically, or is this a population of patients that you are going to be monitoring, much like the EICU methodology?
Well, I think for initial recruitment, it would have to be locally. And for the pilot, we'd have to look into Sacramento County residents. Now, in Sacramento County, based upon the latest data, there are 18,000 people, Medicare, with a diagnosis of COPD.
Okay.
So the population is there. And so we in our office see just the tip of the iceberg, which are typically the sicker of the sick.
Right.
And obviously, a number of my patients in my practice would benefit from something like this. But we also see many patients that are not as well monitored or cared for through the emergency rooms at the various hospitals that get admitted. And we envision trying to create a program to recruit and enroll those individuals into the program. and we'll find out how successful that is once the program is running, assuming it's approved.
Right.
But that's what we envision first is really it's that high-risk population where the capture point typically is going to be in the hospital-based setting. The other component will be an outreach to the varying groups in town, as well as to competing organizations such as in Sacramento there's Kaiser and UC Davis.
Right.
And we want to be open with them as well to offer the services and allow them to participate in this as well. But I think before I can go that next step, I need an actual payment model that I can say, you know, we're going to pilot this. Dr. Louie, you know, at UC Davis, you know, are you interested in, in doing the research and seeing how this works as an independent provider? And so I think, we'll be able to achieve that 2,000 through a variety of means, although I clearly don't have an actual number of distribution as to how that's going to happen.
So thank you for that clarification. And here's directly what I have a question about. This is new, and I was on the ground when the ICU concept came to the fore. And the challenge that we had, which was not necessarily just the challenge within my own practice, was that these patients, if they're not your patients, have very strong relationships because of their comorbidities and just their sort of genetic makeup, if you will. They're very sticky to other physicians.
Exactly.
And the other physicians have a very significant influence over what happens with these patients and what happened in the EICU environment, where you had this cohort of physicians who were not their physicians, but they, by just the nature of the program, were monitoring these patients. And there was a lot of tension between the monitoring physician and the physician cohort that actually had a very strong bond, and patients were. There was a lot of tension, there was a lot of opt-out, there was a lot of challenges in an early adoption. And so I guess I'm curious, have you had that experience, you've thought through those challenges, having been in the trenches?
Well, I was the medical director during the time. And
you're still here to talk to us today.
And so I had to talk about the fact that we weren't Big Brother, and we're not trying to take over the care of their patients. And it took a long time in some instances. Obviously, whenever we did write an order on such a patient, we certainly contacted the physician indicating the reason why we intervened. And but over time, it worked out. They lost fear. But regarding this project, clearly, if we get the green light, one of the first projects is really a physician outreach, town hall if you wish, to find out how do they feel about entering their high-risk patients. What do they get in return? Obviously, we want to make sure that any patient that's entered into the program meets their MIPS PQRS standards so that they can report that. Clearly, we want to be a lifeguard and a safety net for their high-risk patient population, similar to what we do in the EICU. And clearly, we want to figure out how coordination of care should occur without the physician on the other end feeling we're usurping their responsibility and their patient population. And so those are all issues that we look at, and that's why, in part, with the coordination of care, I kind of didn't know what to do with that question.
Yeah, well, and that's something that we'll discuss when that metric comes up a little later. But Elizabeth?
Thank you, and thank you very much for the proposal. I have two questions and a comment. My comment first was just to sort of recognize and applaud your statement that said you were ready to be held accountable for the priorities for whoever is paying you. Having worked with public and private employers, that is not always something that people are so bold about. So I just wanted to recognize that. My question, one is on sort of the HIT aspect of this. I think the PRT, and you've said that there's clearly a technology component that people are comfortable with. I'm more interested in the information sharing aspect of that criteria, and you've acknowledged some potential barriers created by the perhaps lack of interoperability across the HRs. So can you comment on how much of a barrier you think that will be, and some of your thoughts on how that will be addressed?
Locally, it shouldn't be that big a problem. Right now, in our private practice, we use a EMR called Athena, which has no connectivity at all with any of the EHRs from the groups. And so currently we end up faxing and scanning a lot of stuff. But at least within our region, it's starting to coalesce around Epic. The Sutter system has it. It looks like the Mercy outpatient system is going to, or the Dignity now, outpatient system is going to evolve to it. Kaiser has it, UC Davis has it. And so for the purpose of this project, we would probably use Epic as our platform, which allows connectivity to the varying providers citywide. So locally, that's easy. As we think about scaling, it does become an issue. And I don't have good answers to how we would approach and overcome those issues. That's what I think I need an IT, person to talk to other IT people about how we can make that happen.
Okay. Well, thank you. That actually segues to my other question, which is very similar to, I think, Grace's question about scale, because obviously scalability is a key part of our thinking. And my question was more focused on readiness. You have been, I think, extremely candid and open about the unknowns of this model, which is entirely appropriate. It's why you're here. But do you have a sense, and this might not even be fair, sort of the readiness of others in the field to test this, or how much needs to be learned before it is scalable?
I think a lot depends upon whether or not we're as successful as we hope we can be. So, success breeds a lot of interest and taking people off the inertia step. Clearly, if we see signs that this is working very well, we can start contacting other major groups in different cities to see if they have an interest. I mean, we, as pulmonary specialists, we do have a network, and we can utilize that network potentially to scale people into their own communities if they have the interest. But everybody's going to be scared in the beginning because the risk-sharing model I'm proposing is obviously unique. You have concerns about them. They're going to have even more concerns since it would be their money on the line. And so the answer is, if we're wildly successful, then scaling becomes a slam dunk. If we're not successful, it goes nowhere.
Fair enough. Thank you.
Paul?
Yeah, I will just add my gratitude for bringing this forward. Thank you for clearly a lot of work has been put into this. Just a quick question. In BPCI model, one of the clinical conditions is COPD, asthma. Did you ever have a conversation or think about, again, within the physician community that you work in, to participate in that and maybe leverage this as part of that?
No, we did not. I mean, we're not that familiar with that model, to be honest. I mean, most times I'm in the intensive care unit. and so, I don't have, I used to have a big outpatient practice, but I don't now. And from time to time, my interests, aren't necessarily in over there because don't have the time to spend on it. But since this particular project is one I created previously, it was easy to dust off the shelf, honestly, and certainly I could commit to this to the point where I already told my senior part. Actually, I'm pretty senior myself, but my boss that I'm willing to give the ICU back to the youngsters and devote time to this to make it successful.
That's very noble of you. We have no more questions within the committee.
Okay.
Seeing none, I want to thank you again for your attention and the detail and the effort that you put in interacting with us and being extremely specific and helpful in answering our questions as we consider your proposal. So thank you very kindly.
Honestly, I found this to be a very fascinating project. It kind of enlivened my intellectual side after just seeing patients day in and day out. And so I appreciate the opportunity to have a chance to bring this proposal forward and sit before you. And
Thank
if
you.
Blue Shield's interested, I'm willing to talk.
So yeah, we'll talk a little later about that. But again, thank you very much.
Okay, thank you.
All right, so our next section of the meeting is, as we said, being transparent and working with the stakeholder community. We have opened up the floor for public comment. We have some folks on the phone who've been listening in to the entire session, but I'd like to have James Gajewski step up forward if he's here to present. I think I got that right. You'll thank me for that.
I do thank you, but you're only close. It's Gajewski.
Oh my goodness. Okay. Well, maybe another couple sessions we'll get it worked out. Yes, absolutely. Yes.
Anyway, I again want to thank the panel for the opportunity to speak. As I was stated yesterday, I represent the American Society for Blood and Marrow Transplant. I actually deal with a lot of pulmonary disease, primarily bronchiolitis obliterans, but I take care of my COPD and my asthma patients because, as I noted yesterday, I, for 6 months to 1 year to 2 years sometimes, am the primary care physician for this. Yesterday I made lots of comments about the issues of cherry picking and patient access, and I just want to remind the panel both bone marrow transplant has lived under case rates since 1991. We have some outlier clauses, but we live under case rates. We also, since 2005, have had our 1-year survivals published by center. And we have, and now are having physicians and groups having to say no to patients either because we can't get proper compensation or we have to worry about our acuity adjustments issues and our survival. I have been on the front line to say no to patients for therapy when the therapy is their only chance for living. I've also been on the front line for stopping ventilators many times in my life and career as a physician. So these all issues are very personal to me because of the type of practice I have, because I take care of transplants and acute leukemia patients. So acuity adjusters, and I appreciate all the comment about risk adjustment, and I agree perfection will be the enemy of the good, and yet we have to preserve access for these patients. So one of the issues with acuity adjustment is data collection. And everybody here has talked about the robustness of Medicare data, and yet many of us in other settings and venues will say that the claims data for ICD-10 and ICD-9 is very specious. One of the issues for these complex patients is that all of us who are cognitive care providers with these complex patients are billing level 3 inpatient, we're billing level 5 outpatient. Sometimes we get to bill critical care with these patients, but if I do team-based care, I can't bill critical care because those codes were never designed by CPT and RUC for those. The answer for some of Grace's questions, which is not the chronic care management codes, but maybe something that was approved this year, is prolonged service non-face-to-face time that may capture some of this work effort. But it is also very hard for us as cognitive care providers to get that problem list into any sort of claim software to be as robust as it should. And so as I think about COPD and asthma, and many of the people at this table I know have treated COPD and asthma, but how many of you have put in chronic hypoxia? How many have you put in CO2 retention or mixed acid-base disorder with primary hypercapnia? Because these are the patients with COPD who are the most brittle, the worst, the highest complication rate. Also, as we deal with these COPDers. They're also like my patients. They have ischemic heart disease, and there's an interrelationship. Many of them have diabetes. They also have peripheral vascular disease, cerebral vascular disease, all of these things. One of the sad lessons, having negotiated transplant contracts, both with my honorable colleagues from Blue Cross, but with every major payer in the country. I have lived under case rates for commercial payers since 1991. When I was a young man doing those sort of negotiations without all these gray highlights in my hair, I tried to write a contract where we would just deal with the disease, and any comorbidity we would get a supplemental payment for. The problem is when you're looking at a 3 or 6 month payment time period, to say that the creatinine is due to the hypertension or the diabetes versus the immunosuppressive drugs I prescribed, you can't do that. And that's why we've had to live with outlier clauses. But the issue of these comorbidities, and I applaud the presenters for coming up with an idea, but there is going to be risk stratification within. It's not just going to be those 5 comorbidities. The patient with ischemic heart disease who also has an ejection fraction of 30% and has COPD is a very different patient than some of the others with 5 comorbidities. And we are going to have to think about this, or there will be this cherry picking, and the patients most in need of care will be denied access of care. The other issue with a lot of these patients is going to be cognitive decline, and all these new wonderful systems we're talking about require in-home sort of monitoring with electronic sophistication and usually a home caregiver. Well, not everybody has that. Not all these patients, when you hit 65, 70, 75, have a lot of sophistication. And these are patients on 20 meds a day. We can't get a visiting home nurse there every day to help them with medication management. We all try very hard to do that. I also would say that some of the other issues that who takes care of these critically ill patients struggle with is some of the other requirements under MACRA and the some of the things for electronic health care. Having patients have immediate access to my notes. My friends who are mental health providers get some protected space of access for their notes where they can make comments, but anything that affects a patient outcome should be documented in my note. So as I deal with patients going through divorce that hurts, as I deal with cognitive decline, patients with what I feel are personality disorders that is affecting their compliance, where they're actually sabotaging their care, I put those in my notes. They have immediate access to them. I get comments back. It is a huge issue. And so if we're going to do any of these complex patients correctly, how we do this documentation of the complexity is going to be important. How we pay the providers to do this complexity of documentation is important, because the claims data is not as robust as we would like it to be. And to do this well, to preserve access, it will have to be. Final issue, as I think about this model, you really do have a dimorphic patient population between COPD and, if you think about the Medicaid patients with asthma, which will primarily be children, adolescents, and you have to deal with things of dysfunctional home situations. You have to deal with the inability to get homes clean because parents are working, or there's family dysfunction and disaccord. All these things and the emotional health of the environment will drive a lot of the issues. That's data that's never been coded in claims data, number one. Number two, how are we actually going to have some control or do acuity adjustment for that? And yet we must. And so, I commend the presenter for all they have done, but I also need to have this panel to think and deliberate about all these complexities, because these are not easy, but this is what it's like taking care of patients in real-life situations.
Thank you, Doctor. We're now, any other folks in the audience who may want to come forward and provide a public comment? We're now going to have ask the operator to open the lines. I believe there's potentially some folks who may have registered to comment.
At this time, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster. Please press star, then the number 1 if you would like to ask a question. And there are no questions on this end.
Thank you very much. Before we start deliberating, we are going to take a 10-minute recess. Thank you.